For 11 years, every doctor she saw gave her the same answer. It was anxiety, it was stress.
And that's what's causing
It was the kind of suffering that has no visible cause, the kind that medicine has always struggled to name precisely and has always, in the absence of a better explanation, assigned to the patient's psychology rather than their body. She was told to exercise more.
And that's what's causing
She was
the
told to
seizures.
improve her sleep hygiene. She was given referrals to therapists, to psychiatrists, to a pain management clinic.
And that's
She
what's
was
causing
prescribed
the seizures.
antidepressants, and when those did not help, different antidepressants. And when those did not help, a conversation about
And that's what's
acceptance
causing the
and the
seizures.
management of chronic symptoms in the absence of identifiable pathology. She was told in several different consulting
And that's what's
rooms by
causing the
several different
seizures.
physicians who had examined her and found nothing, that there was nothing wrong with her that any scan had been able to find.
And that's what's causing
They were
the
right
seizures.
about the scan.
They
were wrong about everything else. Catherine was 31 years old when the headaches began. Not
that's what's
headaches
causing
in the
the
way
seizures.
most people use the word.
A
A localized episodic pain that comes and goes and responds to rest
And that's
or
what's causing the
analgesics
seizures.
or the passage of time.
What
What Catherine experienced was pressure, a feeling of fullness and weight behind her eyes and across
And
the
that's
front
what's
of her
causing
skull
seizures.
that was present when she woke up, present when she went to bed, and present in the continuous background of every hour
And that's
between.
what's causing the seizures.
It did not throb, it did not spike, it simply occupied her with the patient constancy of
And that's
something that
what's
has
causing the
decided to
seizures.
stay.
It
did not respond to paracetamol. It did not respond to ibuprofen. It did not
And that's
respond
what's
to
causing the
rest,
seizures.
to hydration, to the elimination of caffeine, to the absence of screens, to any of the standard
And that's what's
interventions
causing the
that work for the
seizures.
ordinary headaches that ordinary people carry through ordinary lives. She went to her GP 8 months after it began. He
And that's
examined
what's
her and
causing
found
the
nothing
seizures.
remarkable. He told her that chronic daily headache was common in women her age and frequently had a significant stress component.
And that's what's causing
He
the
recommended
seizures.
she consider her workload, her sleep schedule, and her relationship with work-life balance. She was a primary school
And that's
teacher.
what's causing the
Her
seizures.
workload was considerable, and her relationship with balance was imperfect. She made adjustments. She reduced her
And that's what's
extracurricular
causing the
commitments.
seizures.
She began going to bed earlier. She started running 3 mornings a week on the advice of a follow-up appointment in which her GP
And that's what's
noted that
causing the
aerobic
seizures.
exercise had good evidence for headache management. The pressure did not change. She went back. He ordered blood work,
And that's what's
a
causing the
comprehensive
seizures.
panel covering thyroid function, inflammatory markers, anemia, vitamin deficiencies, the standard
what's
sweep
causing
of
the
things
seizures.
that present as fatigue and head pain, and that a blood panel can rule in or out cleanly. Everything
And that's
returned
what's
within
causing the
normal
seizures.
range. He referred her to a neurologist as a precaution, noting in the referral that the headaches had been present for over
And
a
that's what's
year
causing the
and had
seizures.
not responded to conservative management. The neurologist conducted a standard examination. He tested her
And that's
reflexes,
what's causing
her
the seizures.
coordination, her cranial nerve function, her sensory responses. He ordered an MRI of the brain with and
And that's
without
what's causing the
contrast.
seizures.
The scan was reviewed by a radiologist who noted no significant abnormality. The neurologist told Catherine
And that's
that her
what's
brain
causing the
appeared
seizures.
structurally normal, that her neurological examination was intact, and that chronic daily headache of this kind was
And that's
commonly
what's causing the
associated
seizures.
with underlying anxiety and depression, both of which were well recognized and well treatable conditions. He did
And
not
that's what's
dismiss
causing
her.
the seizures.
He was, by all accounts, a careful and considerate physician. He gave her the name of a psychiatrist and told her that addressing
And
the
that's what's causing the
psychological
seizures.
component was the most productive next step available to her. She went to the psychiatrist. She described her
And
symptoms
that's
fully
what's
and
causing the
honestly.
seizures.
The pressure, the nausea that had begun accompanying the worst episodes by the second year, the visual disturbances that had started appearing intermittently, a dimming and brightening at the edges of her vision that came and went without pattern. The psychiatrist diagnosed generalized anxiety disorder with somatic features. He began her on a course of therapy, and the therapy
that's
was
what's
not
causing the
without
seizures.
value. It gave her tools for managing the emotional weight of living with unresolved chronic pain, but the pressure in
that's
her
what's
skull
causing
did
the
not
seizures.
respond to it.
3
3 years after the headaches began, she noticed the vision problem was getting worse. Not
And
worse
that's
in the
what's
sense
causing
of
the
acute
seizures.
deterioration, worse in the sense of more consistent, more reliable in its presence. A dimming at the
That's
lower
what's causing the
periphery of her
seizures.
visual field, particularly pronounced when she was tired. She noticed it while driving. The right lane marker on a motorway seemed to fade in and out at the edge of her awareness in a way that unsettled her. She mentioned it at her next therapy appointment. Her therapist referred her back to her GP. Her GP referred her to an ophthalmologist. The ophthalmologist conducted a thorough examination. Her retinas were healthy. The structures of her eyes were intact. Her visual acuity was normal, but her visual field test, a mapping of the full extent of what she could see in her peripheral vision, showed a pattern of loss, concentrated in the lower quadrants of both eyes, that the ophthalmologist recognized as consistent with pressure on the optic nerves over time. He asked her how long she had had the headaches. 3 years, she said. 4, approximately. He asked whether anyone had ever measured her intracranial pressure. No one had. He wrote a referral to a neurologist at a tertiary center and marked it urgent, specifying the visual field findings and his concern about elevated intracranial pressure. He told Catherine to go directly to the neurology department and not wait for a scheduled appointment. She went the following morning. The new neurologist ordered a lumbar puncture. A lumbar puncture, the procedure involves inserting a thin needle into the space between vertebrae in the lower spine, accessing the cerebrospinal fluid that surrounds and cushions the brain and spinal cord, and measuring the pressure at which that fluid stands. The procedure takes 20 minutes in a clinical setting. The result is a single number. Normal opening pressure ranges between 10 and 20 centimeters of water. Catherine's opening pressure was 38. Her brain had been sitting inside a skull pressurized at nearly twice the level it was designed to tolerate. For somewhere between 3 and 11 years, the lower bound representing when the visual field damage became measurable, the upper bound representing when her symptoms had begun. The fluid surrounding her brain had been exerting a force against every structure it enclosed, including the optic nerves which exit the skull through small openings, and which, under sustained elevated pressure, sustain damage that accumulates silently and does not reverse. The condition was called idiopathic intracranial hypertension. Raised pressure within the skull and around the brain, with no identifiable tumor, no blockage, no obstruction to the normal circulation of cerebrospinal fluid. Idiopathic, meaning the underlying cause is unknown. It occurs more frequently in women, more frequently in women of childbearing age, and more frequently in women who have experienced significant weight change, though the mechanism connecting these factors to abnormal CSF pressure remains incompletely understood. It is a condition that mimics anxiety in its early presentation. The unremitting headache, the nausea, the visual disturbances that come and go without apparent pattern. It is a condition that an MRI does not reveal because the brain itself is not structurally abnormal. The problem is the pressure around it, not the tissue within it. It is a condition that requires a lumbar puncture to diagnose. And a lumbar puncture is not part of the standard workup for a young woman presenting with headache and a normal MRI in documented anxiety. The neurologist sat across from Catherine and explained all of this. He explained the pressure, the mechanism of optic nerve damage, the treatment pathway, a medication called acetazolamide, which reduces the rate at which cerebrospinal fluid is produced, combined in her case with a procedure to more immediately relieve the accumulated pressure. He told her that treatment was effective in controlling the condition and preventing further vision loss. He told her the vision she had already lost would not return. Catherine asked why no one had found this. He said, "Because the MRI is normal. And when the MRI is normal and the presentation includes anxiety and chronic headache in a woman your age, the diagnostic pathway that most physicians follow does not lead to a lumbar puncture. It leads to psychiatry. That is a gap in how we are trained to think about this presentation. It is a gap that costs patients like you years of their lives and, in some cases, their vision." Catherine began treatment within 2 weeks. The headaches responded within the first month. Not dramatically, not instantly, but progressively, the pressure in her skull descending toward a normal range and taking with it the weight she had been carrying for so long that she had partially stopped believing a different state was possible. She was 42 years old, She had spent 11 years being told that the problem was in her head. It had been. That part had always been accurate. The problem had simply been physical. The kind of physical that requires a pressure gauge to find. The kind that a scan cannot see and that a psychiatric referral cannot treat and that accumulates in silence behind every normal test result, pressing quietly against the structures of the brain while the patient is handed another referral and told to work on her resilience. Idiopathic intracranial hypertension is not common, but it is not vanishingly rare either. It affects an estimated 1 to 2 people per 100,000. Because it disproportionately affects women of childbearing age, and because its presentation overlaps so precisely with the profile that attracts a diagnosis of anxiety. Chronic headache, normal imaging, subjective symptoms without objective correlates. It is routinely delayed in diagnosis. The average delay across multiple studies is measured in years. The optic nerves do not wait for the diagnosis to arrive. Catherine knew this. She had done the reading after the diagnosis, the kind of reading that patients do when they finally have a name for something that has been nameless for a long time. She read it carefully and she did not read it with anger. She said because she was past the point in her life where anger felt like a productive allocation of the energy she had. She read it so she could explain it accurately when the opportunity arose, so that if someone she knew described a headache that would not go away, a normal MRI, a referral to a psychiatrist, a visual field that seemed to be fading at the edges, she would be the person in the room who knew what question to ask next. What is your intracranial pressure? It is not a question that requires medical training to ask. It requires only knowing that the question exists. Catherine spent 11 years not knowing the question existed. She has spent the years since making sure the people around her do.